Good afternoon, everyone. And first of all, I would like to thank the organizing committee for inviting me to share this case. Okay, let's start the case presentation. This is 42 years old man who has never known HIV-0 status before. He presented with 6 weeks of non-productive cough, night sweat and fever, followed by watery diarrhea for 4 weeks, and he lost his weight about 3 kilograms. On physical examination, he had low-grade fever, tachycardia, and hypotension. He was also has anemic and had oral thrush, but no lymph node palpable and no hepatosplenomegaly. The skin lesion here, you will see that symmetrical distributed itchy papular eruptions. And the ophthalmologist did the exam and no evidence of CMV retinitis. The investigation showed low hemoglobin level and have 2-fold increase in transminase enzyme. Stool exam showed no white blood cell count, and other stool study was not performed at that time. Skin scraping for right stain, no fungus found. And this is the X-ray on the first day, that no definite pulmonary infiltration. He was hydrated for 12 hours and then asked for a discharge home. And the next visit was scheduled for 2 weeks. The other results available later include sputum AFB for 3 days and no AFB found. And CD4 cell count was 73 cells per mil, which is 3%. I would like to stop at this slide for 5 seconds. And I want you all to have differential diagnosis in mind. What do you think is the cause of chronic cough in this patient, and what do you think the cause of chronic diarrhea in this patient? Okay, let's back to the case. So the patient was called 1 week later because hemoculture showed the mole, as you see here on the left. This colony was incubated for 6 days, and you will see the colony of the mole is white to yellow and produced red pigment into the agar, and was finally identified as Thalassomesis manifesti. At that time, he had fever, tachycardia, hypotension, and the hemoglobin, white blood cell count, and platelet count was dropped from the first visit, which may not or may indicate that have the bone marrow involvement. So the learning point for thalassomicosis: almost but not all patients presented with fever at the first time of presentation. The skin lesion that is typical can be found in 70%. And this shows the typical skin lesion, or sometimes we call umbilicated skin lesion. You will see like central necrotic papules and sometimes nodules. And if you scrape at the bottom of the central necrotic lesions, you will see pleomorphic yeast cell. And if you see in the detail, you will see binary fission, which is the way how this organism reproduces. Patients with thalassomicosis may have cough in about 40% and also have diarrhea about 30%. And the clinical specimen that T. manifesti can grow mostly from the blood, skin biopsy, or scraping, lymph node, and bone marrow. So let's move to the second problem of this patient is chronic diarrhea. Although the patient with thalassomicosis may have diarrhea for about 40%, but it's not the common cause of diarrhea in HIV-infected patients, so concurrent opportunistic infection must be investigated. And this is a study done in Cambodia that the most common cause of chronic diarrhea, the first rank was mycobacterial infection, followed by cryptosporidium and other parasites. In these patients, stool examination was performed many times and no white blood cell show. Stool modified FB show spherical and a little bit ovoid shape oocyst, which is compatible with cryptosporidium, and stool culture also grew some non-typhoidal monolar. This is a timeline of the patients. The patient received amphotericin B and also ciprofloxacin according to the culture result. However, one week after hospitalization, the patient still had fever, dyspnea, and also required oxygenation. And the chest X-ray at that time showed bilateral, interstitial, and alveolar infiltrations. So the patient was intubated, and the empirical treatment for pneumocystis pneumonia and hospital-acquired infection was empirically started. The fever was dropped, but could be from dexamethasone. The BAL was performed 3 days later after intubated, and the cytology showed neither viral inclusion nor fomic exudates. On the 9th day of treatment, the patient's condition did not improve, and also he had to be kept in the prone position. So the BAL was again performed, that is 1 week apart from the first BAL. And the cytology showed pneumocystosis with CMV cytopathic effect. And on the same bout, NTB was detected and resistant to rifampicin. And on the same bout, the culture grew carbapenem-resistant Klebsiella pneumoniae. So the learning point for pulmonary infection in HIV-infected patients, majority of lung infection is from bacterial pneumonia, and Streptococcus pneumoniae ranked the first. The second rank of the pneumonia in this group of patients is pneumocystis pneumonia, followed by mycobacteriosis. And you will see here that only 5% of pulmonary infiltrates is caused by virus. Ganciclovir anti-tuberculous drug without rifampicin was started. Amphotericin B was switched to itraconazole mainly because of acute kidney injury. And finally, the patient received antiretroviral with TDF, FTC, and efavirenz. The clinical course of this patient, the diarrhea resolved finally, and the fever effervescence. The patient has complicated with hospital-acquired pneumonia. The patient can discharge home, that is very, very great, after 3 months of hospitalization. Currently, he is taking tenofovir, FTC, and DTG, and the CD4 count this year is 637 or 23%. That is 5 years after treatment. In the summary of this case, the patient had multiple opportunistic infection. First, tularomycosis. Second, chronic diarrhea from Cryptosporidium and non-typhoidal Salmonella. Third, pneumonia from Pneumocystis jirovecii and CMV. And lastly, with pulmonary tuberculosis, which is resistant to rifampicin. These are the summary of the table that the patient received for the treatment for particular opportunistic infection. At the bottom line for the pulmonary tuberculosis, as this patient, we treat him last 5 years ago. So this is not the best regimen at this point. Presently, if you will treat mono-rifampicin resistant, the best regimen is shorter or oral bedaquiline containing regimen, as you will see in the bottom. I think few people can remember all the regimen here, but every time you will treat the patient with multiple opportunistic infections and who receive multiple medications, you have to check for the drug interaction with the medication for treatment opportunistic infection and for the treatment of HIV with antiretroviral. So I would like to close this case here, and thank you for your attention.
Yeah.